So regarding CAR-T cells for CLL and Richter syndrome, so the prognosis of CLL patients has improved a lot in the era of targeted therapy. Anyways, when a patient do relapse or is refractory to targeted therapies like Ibrutinib or Venetoclax, and especially if this patient harbors high-risk cytogenetics like TP53 alterations or complex karyotype, they also face a grim prognosis. So there are several groups that have been developing CAR-T cells for this type of population, with somehow complete responses that ranges from 20% to 45%, which in comparison to other CAR-T cell therapies in other histologies like acute lymphoblastic leukemia or diffuse large B-cell lymphoma is frankly worse outcomes. So what we wanted to see is how these patients respond to our academic CAR construct, which is called ARI-01 cells. So here we have recently reported the outcomes of the first 9 patients, the first 9 consecutive patients with CLL and or Richter transformation treated with this therapy. So we included 9 patients with a median age of 58 years and a median of 5 prior treatment lines. 90% of them were relapsed or refractory to Ibrutinib and 56% to Venetoclax. So we were able to give them the cells, the CAR-T cells, with a median vein-to-vein time of 27 days. Finally, we treated 8 of 9 patients. 1 patient didn't get the cells due to progressive disease during the first lockdown of the COVID pandemic. And the patients that did receive the cells, we did see at 87%, almost 90% of CRS rate that was severe in 12% of them, with a requirement of use of Tocilizumab of 37%. On the other hand, we saw no case of ICANS. And regarding efficacy, what we saw is that all patients achieved an absolute B-cell aplasia that was not as fast as the first week like we used to see in ALL and diffuse large B-cell lymphoma, that take a little bit longer, 2 to 3 weeks to achieve absolute B-cell aplasia. But once they achieve this, the median duration of this absolute B-cell aplasia has not been reached at the 1-year mark. And also regarding efficacy, we have seen a 100% of MRD negative complete response rate, both in the bone marrow and the peripheral blood for the CLL component. And on the other hand, the Richter component, we have seen a 60% of unrelapsed complete metabolic responders, with 2 patients that did get an initial response, an initial PR or stable disease, and that later progressed due to a CD19 negative escape. So just to sum up, we have seen in this very, very small cohort that patients with CLL and Richter transformation can respond to CAR-T cell therapy. Usually responses, we haven't seen any relapse of the CLL, which is somehow surprising. And we also think that maybe it's better to treat patients with high-risk CLL before they get the transformation to Richter's, because once they get this transformation, they will still be able to respond to CAR-T cell therapy, but maybe with lower response rate than if the patient was treated with only CLL. So this will be all for ARI-01 cells in CLL and Richter transformation.